All right, thank you, ladies and gentlemen. Hope everyone enjoyed their dinner. I'd like to just briefly introduce our two speakers. We'll have James speaking first, followed by, sort of during James's talk, Jason will give a short talk, and then James will finish up the evening. James O'Byrne, for those who don't know him, is a senior staff specialist in hepatology at the Sunshine Coast University Hospital, having worked for over 10 years as a consultant at the liver unit at the Royal Free. Now, his official bio says that he emigrated to Australia in search of vitamin D, which is probably unsurprising. There we go, that's me being live. But he has research interests in portal hypertension, HCC and critical care in patients with liver disease. Tonight he'll be talking to us about variceal bleeding and give us an update on the latest Bovino guidelines. Jason Huang is probably better known to some of us as a local trainee, someone who works at St Andrews, Holy Spirit Northside, and also the Royal Brisbane Hospital as an interventional gastroenterologist. He's talking to us tonight about EUS-guided portal pressure measurement, which formed part of his interventional endoscopy fellowship at UC Irvine in California. So we're lucky to have two very experienced and good speakers in these topics on portal hypertension, something that hopefully will appeal to everybody. So without further ado, I'll introduce James. Thank you.
Well, thank you very much, Richard, for the kind invitation. And Tony, I think, originally invited me, and then obviously he's heard me speak before, so he took his leave. And he gave me the topic of speaking about variceal bleeding, which, to be honest, you've probably heard talks on variceal bleeding a million times, and I apologise for that. I've not really got a lot new. But what I thought I might do is just talk a little bit about variation in... hold on. Variation in care. This is your talk, Jason. Let me find mine. Yeah, okay. Talk a little bit about variation in care and talk a little bit about the Bovino consensus conferences and what was new out of the last Bovino and how that particularly can shape our research interests over the next few years and really generate some ideas and some discussion about what we think is important in the management of variceal hemorrhage and how we can improve it. So for those that don't know, but the Bovino consensus conferences started in 1990 as an attempt to try and standardise definitions in portal hypertension to allow trials to be compared and allow meaningful trials to be conducted. And then it grew both in size and in scope, and it started to involve guidelines and then defining research priorities. And every 5 years, a conference is organised where experts meet and try and come up with these consensus statements about how the research over the next 5 years should be conducted, what are the endpoints, what is the current standard of care. And I think they've stood the test of time, 1,700 citations since 1990, and I think because of their international scope are still considered the best guidelines in portal hypertension. But I suppose many of you in the audience are probably thinking, well, why bother? Acute variceal bleeding, well, we all know how to manage it. And in fact, this data would suggest that actually it's a done deal. You know, there's decreased in-hospital mortality in the UK, in the US, in Europe, and indeed in Australia over the last 20 years. The table just on the right show, if you look on the third column along, is the decrease in ICU mortality from variceal bleeding in Australia, and you can see how that's decreased in time. And this is in the face of an increased detection of varices in outpatients. So you'd like to think that maybe we're on top of the problem, and this talk is totally superfluous. However, what we haven't really addressed is the fact that the 6-week mortality is still 10 to 20%. And the 1-year mortality is still 50 to 60%, and that has not really changed in that time. So while we've got better at managing the acute bleeding event, what we've not been very good at is translating that into prolonged survival. And there may be a number of reasons for that, but one of the reasons might actually be not adhering to guidelines and variation in clinical care. So this was a small study, but I think quite interesting. This study from the US, I think, was of 99 patients with a first variceal index bleed, and then they just followed up what happened to those guys over a year. And out of the 99, despite the aim should be, of course, that those patients should have banding eradication, only 66 had incomplete obliteration. 46 of that cohort did not receive a post-discharge endoscopy, which is pretty shocking. And only 12 of that original cohort actually adhered to the full 1-year surveillance program, and perhaps unsurprisingly, 46 of the cohort were readmitted with another variceal bleed within a year. So we've got good at managing the acute bit, but I think there's some room to get better on the follow-up bit. And certainly when you look at whether people adhere to published guidelines in the management of variceal hemorrhage, there are a couple of studies now showing some quite staggering defects in care, with no endoscopic therapy in 14% of patients who get admitted. Balloon tamponade, which I think is a marker these days of poor technique or inability to control varices, and then antibiotic use being missed in nearly 50% of patients. And antibiotics, as I'll show you, are obviously a key component in the management of variceal hemorrhage. Okay. Feel free to interrupt or shout out, that's fine. So I come from the UK, where it's terrible. And so this is a word cloud of a talk we did at the British Society of Gastroenterology meeting in 2016. And we asked the question, what single intervention do you think would improve the outcome of variceal bleeding in your hospital, or trust as it's called there? And you see there's such a wide variation of answers there in terms of, we need good ITU support. How many of these say out of our service, no GI bleeding rota? I mean, it's impossible to even believe that in the UK there are hospitals that admit patients with acute variceal hemorrhage that don't have an on-call endoscopy service. And I can tell you my experience of working in Australia so far is that you guys are much better set up in terms of inter-hospital transfer than we are in the UK. And that perhaps is the reason why when we ask the question, how quickly does your local radiology hub provide an urgent tip service? And you can see that sometimes it's the same day, 12 hours, 1 to 7 days, not quickly enough. It's the raw free. Well, there you go. That's good. And days to weeks. It's just not good enough, especially in the era where we're actually talking seriously about offering early tips to people who are high risk. So even in that relatively small, and how many UKs are there in Queensland? 28. 13. So even in the UK, we can't sort that out. So I think, in Queensland, maybe you guys are a bit better, I don't know, but it's a problem, variation. And then we asked this question, because the Royal Free being a tertiary referral centre we used to get a lot of patients transferred in because of gastric variceal bleeding. And gastric variceal gluing, I don't think, is a rocket science technique, but you can see from this cohort of consultant gastroenterologists largely at the British Society, the majority of them did not feel competent in gluing gastric varices. And I get a feeling that gastric variceal bleeding is becoming more common. It certainly is scary when it happens, but I also think that glue is not a difficult technique if it's done properly. I do also think, though, that if you're over at that far end, where you're beamingly happy, saying, I'm fantastic at glue, you're probably lacking a little bit of insight. So what does this variation actually look like to the patient? And it looks pretty grim. So this is a photocopy I took of a real endoscopy report of a patient who's transferred in. And you can just scan through that and just know that things are not going badly. This is like a shopping list of how not to do things in a variceal bleed. Patient's not intubated. They're already desaturating prior to the procedure. They struggle to get some bands on. They're still bleeding. A Sengstaken-Blakemore tube goes down. The patient's then in extremis at the end with the SATs down to 85%. And then suddenly, maybe we might intubate the patient. And this is, I think, what happens when you put the endoscopist at the top of your totem pole of priorities in the management of variceal bleeding. Needless to say, this patient died because they'd aspirated. This patient Very similar presentation with a massive GI bleed. The first step is intubation, then a Seng-Stark and Blakemore tube, then the massive transfusion protocol, and then towards the end of that sequence is the endoscopist, who perhaps in a massive GI bleed like this has the least to offer. So that's just a background to variation in the management of acute variceal hemorrhage, which I think is difficult to justify when we have really good evidence-based guidelines in how to manage these patients. So I'm going to go back to key statements from the Baveno in 2015, and we're going to talk a little bit about transfusion triggers and targets, prevention of infection, management of gastric variceal bleeding, the role of early tips, and I want some discussion about that, management of treatment failures, and then sort of where the research agenda comes in, and then we'll bring in Jason to talk a little bit about HVPG measurements. So I'm going to show you the Baveno statements and then just a little bit of background. So the first statement was about transfusion, and this was new, and we'd known for a long while that if you transfuse or over-transfuse animals, people with portal hypertension, they bleed more. But this statement was made on the basis that there's now been a very large randomized study that contained lots of serotics that proves, I think without a shadow of a doubt, that over-transfusion is bad for your patients with bleeding varices. So a target hemoglobin level between 7 and 8, so a transfusion trigger of 7, and then a recommendation based on the management of coagulopathy, which I think is a very elegant way of saying there's no need to give FFP and platelets because it doesn't make the blind bit of difference. There's no evidence. There's been 2 big studies of recombinant factor 7 that have made no difference. So coagulation, don't worry about it. So this is a study, of course, that led to the statement about the transfusion target in variceal bleeding. And this was transfusion strategies in acute gastrointestinal bleeding, which was from 2013 in the New England. And they had 2 groups, the restrictive strategy group and the liberal strategy group, with a transfusion trigger of 7 and 9 respectively. And the target was between 7 to 9 in the restrictive strategy, and the liberal was 9 to 11. And I think generally when I was growing up, we'd generally think that, you know, in a bleed, liberal strategy of aiming for a hemoglobin of like 10 or 100, whatever you want to call it, would probably be reasonable. And but like many things in critical care, less is more. And in this study, I think was really good because it actually had a significant number of patients with cirrhosis. And they also did HVPG measurements on these cirrhotics, and they had paired measurements before and after transfusion. And in the restrictive group, if you look at the event rate, so patients Child-Pugh class A or B, 12 out of 113 bleeds in the restrictive strategy versus 23 in the liberal strategy. That was significant. Not significant in the Child-Pugh class C. Perhaps other factors like the severity of liver disease were more important there. Bleeding from esophageal varices, again, was significant. And the use of rescue therapies such as TIPS and balloon tamponade was significantly more frequent in the liberal strategy group. But what I really like about this is it shows that the HVPG in those patients in the liberal transfusion group actually increased where there was no change in the restrictive strategy group. And that median HVPG of 20 is important because that is the cutoff between a good outcome from bleeding and a bad outcome from bleeding. And these were significant numbers, 74 and 76 with paired measurements. So less is more when it comes to blood, less is more when it comes to coagulation factors, and perhaps less is more with antibiotics, certainly for Child-Pugh class A patients, who don't really, if you dig down into the data, seem to benefit that much from prophylactic antibiotics. But in the Baveno consensus conference, it was considered a bit too complex to try and stratify. We're going to give antibiotics to some patients with variceal bleeding, but not to others, based on their Child-Pugh class, especially when there's data suggesting that they don't get given in half the patients anyway. So the statement stayed that antibiotics are important in the management of variceal hemorrhage for a number of reasons, but also A big change from the previous Baveno consensus was now that intravenous ceftriaxone rather than fluoroquinolones was recommended, and that's because of the rise across the world in fluoroquinolone resistance. Now, we should really be knowing what our local antibiotic resistance patterns are, and perhaps, although this says intravenous ceftriaxone, it's important to remember that all antibiotics seem to be helpful in patients with variceal bleeding for a number of reasons. Bacterial infections are really common in patients presenting with bleeding. Every single study of prophylactic antibiotics has shown a benefit, and so there have been single studies and meta-analyses showing a reduction in mortality just through the use of antibiotics. They reduce the 7-day rebleeding rate. We know that infection might be a trigger for bleeding because of changes in the portal circulation, and infection itself can have a heparin-like effect on the blood and can promote a coagulopathic state. So treating infection or preventing infection is really important, but it doesn't just stop there, because what I think we're seeing now with the rise of antibiotic resistance and the prevalence of multi-resistant strains is this concept of breakthrough infection. And this was a study by Punita Tandon's group from last year, a mixed cohort from Canada and Spain. All of the patients presenting with variceal bleeding, treated with prophylaxis, 50% with a third-generation cephalosporin, 50% with a fluoroquinolone, and they actually noted fairly high incidence of breakthrough infection. 14% usually occurred between day 2 and day 7. This is despite prophylaxis. The peak incidence around about day 5, so you could argue these are nosocomial infections. And they noted that there was very high rates of third-generation cephalosporin resistance, and especially ESBL in Spain. Now, ESBL is something that I've seen certainly in my hospital here on the Sunshine Coast, but is absolutely rife in Europe, a really big problem. And what was quite important about this study is that breakthrough infection was an independent risk factor for mortality. So I don't know whether we've got a pointer. So if you look at the graph on the right-hand side, for any given MEL score, if you have a breakthrough infection, you double your risk of mortality. So I think there's lots of work that can be done in terms of getting antibiotic prophylaxis right, especially in an era of antibiotic stewardship, and perhaps there are alternatives to antibiotics or adjuncts to antibiotics which we should be using to try and reduce this risk of breakthrough infection. Somebody will mention probiotics or the microbiome shortly, I'm sure. So endoscopic therapy really hasn't changed. Banding, ligation, and this is just for the trainees, is absolutely the mainstay and what you should be doing. Sclerotherapy should be abandoned. There are, of course, some times where sclerotherapy has to be used, but they're rare. And I will show you an example of just exactly how much damage you can do to an esophagus with sclerotherapy later on in the talk. Endoscopic therapy with tissue adhesive is recommended for acute bleeding from isolated gastric varices and GOV2, i.e. any gastric varix that isn't running down the cardia, which can be treated with banding. And that's a fairly strong recommendation. So I just wanted to show you this really for the trainees, because it's just a very nice, oops. See, I told you, my videos always something goes wrong. There we are. So I just love this because it's a really nice example of a white nipple. And so there's the smoking gun just peeking in at the side there. And just a reminder for the trainees that you should always try and get your bands on low, as close to the GOJ as possible. Very rarely would you need to put on a band higher than 5 centimeters above the gastroesophageal junction. The risk there is there's a very high prevalence of perforator veins, so when you get ulceration, which you always do after banding varices, those perforating veins can bleed torrentially. So keep the bands down low. But in terms of gastric varices, don't use clips. It might work acutely, but you've just shunted the problem into somebody else's on-call night. So it certainly does control acute bleeding. These are 2 examples, but I wouldn't recommend it. The mainstay is, of course, glue injection. So This is somebody who's presented with a variceal bleed. I think her hemoglobin was 26 when she came in. And you look down expecting to see varices, and there's a little one there on the right. So you sort of know what's coming. You go into the stomach, and then you go, oh, there's the clot. So you know what's underneath there, and there it is. So that's a varix which is beautifully positioned for glue injection. And we use a mixture of 1-to-1 histoacryl and Lipiodol. There is great variation, and there's not one study that says this is the best glue mix to use than another. I think what's really important is to get your setup right so the nurses know what they're doing. And I think it's also important that you wear eye protection. Lipiodol is meant to stop the histoacryl from polymerizing quickly. I think it does probably increase the risk of embolization, but I find it easier to work with Lipiodol and histoacryl than just histoacryl alone. What I think is key to managing gastric varices is to not inject too much glue. So we never inject more than 2 mils at any single injection, but some varices are quite big and you want to do the job properly. So what I do is I'll do an injection, I'll then assess, and then I'll probe the varix with a sheathed needle to see if there are any soft bits that need another go. So this is just me pressing the sheathed needle. You can see that's quite hard. And then there's a soft bit, and that's where your next injection would go, to just make sure you've got it completely blocked. There's no really need to inject really more than 4 or 5 mils at any particular go for a big varix like that. You do that, you're just increasing the risk of distal embolization. But again, I'm just telling you that from experience. There is no controlled data to say that this is the right amount, that's not, and that is or isn't the right amount. There are actually a few studies that, one of the best studies showing a reduction in rebleeding rate uses histoacryl on its own without any Lipiodol. We abandoned that some years ago because you can get in this situation. So you can imagine what's going through your mind now. Thinking, I've decided to video this because I want it to be a training video. And yeah, but luckily all goes well. And then the other thing to do is to make sure you're a decent endoscopist, because it looks easy, but you can get the angle sometimes a little bit wrong, and you turn a control situation into something that, yeah. But luckily, and I think this is a nice video because it shows how quickly glue can control a big bleed like that. And that patient did fine. But as much as I'm keen on the use of glue, I've certainly become more cautious over the years, because I think experience of cases really does inform your own practice. This is perhaps one of the worst examples of a glue complication. So, some bits of Lipiodol in the chest x-ray. Sometimes that happens, Lipiodol can get out. It doesn't mean that this is all glue. But the top panel on the right, you can see the glue in the gastric varix. And then this is a patient who had actually quite a large shunt and had quite a large splenorenal shunt. And the glues managed to cross via the renal vein and end up in the IVC on that panel. And unfortunately, that then resulted in an IVC thrombosis with secondary infection and repeated episodes of bacteremia. And that patient was in hospital for about 6 months. And subsequently did okay and got transplanted. And everybody had forgotten about this glue complication until in the middle of the transplant, the surgeon found he couldn't cut through the IVC. But nonetheless, so be careful. And again, less is sometimes more with glue. Just check that you've got the varix all nicely occluded, and then you're done. And it does work. So these are a number of studies looking at the acute hemostasis rate with glue and looking at the eradication rate. And but what you will see is the rebleed rate is fairly heterogeneous and can be quite high in some of those rather small studies. So having got the patient out of trouble with a glue injection, you then have to think about what do we do next. And this is where the data gets really quite sparse. And this, I think, is an opportunity for actually doing a really nice study to be able to define what is indeed best practice. Because despite gastric varices being not uncommon, you'll find that actually the number of randomized controlled trials is actually very few, certainly in the prevention of rebleeding. So there are 2 studies comparing beta blockers versus glue. So that's repeated glue injection. There's 1 study looking at beta blockers plus glue versus glue. And then there are 3 studies of glue versus tips, but all of those studies were using uncovered stents in an era where perhaps there wasn't the traditional standard of care. And are they really relevant? They're all very small. I will tell you that, personally, I think that if I had a gastric variceal bleed, I'd be looking to have a TIPS as secondary prophylaxis because the rebleed rate is so low. But I've also had patients who've been completely disabled by encephalopathy through a TIPS for gastric variceal prophylaxis. So I'm undecided. I think you have to discuss it with the patient. But what we really need is evidence. It's perfectly okay to use glue with a second injection, coming back 2 to 4 weeks later, which is what Baveno recommend. So this is glue versus non-selective beta blockade. 67 patients randomized to cyanacrylate, 1 to 2 sessions as follow-up. No Lipiodol, so this was just straightforward glue. And these guys had optimized non-selective beta blockade. So they were started on 40 milligrams BD. They were brought back a week later. If they hadn't reached a target hemodynamic rate of a pulse rate down to 55, they had their beta blocker doubled until they fell over or complained of side effects. And they also had HVPG measurements, and 40% of these guys were responders to beta blockers, which is sort of what you'd expect from the best beta blocker response you can get. And those panels on the right show the rebleeding rate and the survival for cyanacrylate versus beta blocker. And it looks very clear, albeit in this very small study, that repeated glue injection is reasonable. What about adding glue to beta blockers? So what about using glue and a beta blocker versus just glue alone as secondary prophylaxis? That's only been looked at in 1 study, a bit larger this time, 95 patients, and this was cyanacrylate with Lipiodol plus or minus a titrated beta blocker. So this wasn't, here's 20 milligrams of propranolol twice a day and off you go. This was really targeted, pushing up the dose of beta blocker to try and get a hemodynamic response. And you can see from the rebleeding and the survival curves that there's no difference between glue injection and combination therapy, suggesting that at least in the small studies we have so far, in the field of gastric varices, beta blockers don't bring much to the party in terms of secondary prophylaxis. And I think this is perhaps why this statement from Baveno is a bit woolly, because the trials are not that great. So what they're saying is to prevent rebleeding from gastric varices, you can either use glue, you can either use beta blockers, you can either use the TIPS, and more data are needed. And I think this is a real opportunity. So talking of TIPS, one of the strongest recommendations that came out of Baveno was the use of early TIPS. And this is patients who are considered high risk, should, and not even should. It's a very strong for a guideline document or a consensus document. And early TIPS with PTFE covered stents must be considered in patients bleeding from esophageal varices or gastric varices who are at high risk of treatment failure. And they define that high risk as being patients with Child-Pugh C, class disease with a score of 13, with a score of 13 or less, or Child-Pugh B with active bleeding. And these were the criteria for high risk in this seminal Garcia-Pagan study that was published in the New England. But they also make a statement of the criteria for high-risk patients should be refined, and they should be. Because I think on the basis of the evidence we have so far and the definition of high risk, we're potentially missing an opportunity and muddying the waters. So what is high risk? Well, this all came really from some seminal studies that were done many years ago now, looking at the HVPG, the hepatic venous pressure gradient, in patients who had bled, and this was measuring their HVPG very close to that acute variceal bleed. And this very nice study from Moitino showed that HVPG greater than 20 was associated with longer ICU stay, longer hospital stay, greater transfusion, and much worse survival at 1 year, 20% versus 64% if you had an HVPG less than 20. So that led to the concept of, well, okay, if portal hypertension is so important in the outcome long-term of patients who bled, perhaps if we intervene early to prevent rebleeding and to control portal hypertension, maybe that'll be a good thing. And this was the rationale behind the Monoscilo study that was published many years ago now, which was, I think, quite a brave study to do. They took patients with acute variceal hemorrhage and they gave them all the HVPG measurement in the first 24 hours, and the ones with a wedge pressure gradient of greater than 20, they randomized to an immediate TIPS or standard of care at the time. And they compared the outcome to those patients who had HVPG of less than 20. And you can see quite marked differences in the mortality of these patients. So in the high-risk non-TIPS group, the in-hospital mortality was 38%, and compared to 11% in the high-risk TIPS. At 1 year, the mortality in the TIPS group was 31%, and the mortality in the high-risk non-TIPS group was 65%. And this was quite a logical study to do in many ways, but I think the results were really quite striking. But of course, then immediately people said, well, we can't do an HVPG, in the 24 hours after the patient's bled. We need some other way of defining high risk. And Juan Abraldes came along and said, well, okay, I've got 117 patients here. I've measured all their HVPGs, and I've linked these 3 factors to treatment failure at 5 days. HVPG greater than 20, and 20 is a really important cutoff, shock on admission, or a non-alcoholic component of cirrhosis. And what was really interesting about this is that you could remove HVPG from this model and replace it with Child-Pugh C, and the discrimination remained exactly the same, meaning that actually your strongest predictor of outcome is your Child-Pugh C class, not necessarily your HVPG, and the two probably reflect the same thing. So these are really clinical correlates of an HVPG greater than 20, otherwise known as being high risk. And then that's what led to the seminal study, which again is quite small, multi-center, patients with variceal hemorrhage with either Child-Pugh C or Child-Pugh B with active bleeding, randomized to early TIPS within 72 hours or standard of care. You will notice that 360 patients were screened for this study and only 63 patients enrolled, which I think tells you a little bit about the applicability of this. But the results were really quite striking. Early TIPS definitely reduced the risk of bleeding compared to drugs and banding. Surprisingly, encephalopathy was less frequent in the early TIPS group, which seems quite odd when you're thinking about it, but in many ways, if you're preventing that second bleeding episode, which you will do with the TIPS, that's a second hit to liver function, and you maybe maintain a bit more liver function if you've got a TIPS in, but it's still appreciable. It's still 20% at 6 months. But perhaps what's more striking is the effect on survival. And this was a landmark study, and everybody said, right, we need to start doing early TIPS. And then there was a real world study, and then there's another study looking at historical controls. And the data's a bit of a mess, to be honest, for a number of reasons. So the treatment failure arm in that original study where they were doing the HVPG within 24 hours was really high. So the treatment failure, if you look down at the bottom, composite endpoint or 5-day failure was 50%. That's very high. And these patients were not being treated with standard of care that we'd know it at this day. They were being treated with sclerotherapy, some without antibiotics, some with. So you need to really compare, well, what's the rebleeding rate or the 5-day treatment failure rate with standard of care? And actually, you also need to consider, is Child-Pugh B with active bleeding really a high-risk group? How do you define active bleeding? Richard's active bleeding might be very different to my active bleeding. There's no quantification of that. It's just active bleeding. Well, what does that mean? Does it mean blood in the stomach? Does it mean an ooze? So it's really never been validated as a feature of being high risk compared to the current standard of care. And then in this Rudler study down at the end, where they looked at the real world applicability of this strategy of doing early tips in high risk people, and majority of those patients were Child-Pugh C. They were quite sick. They had a high MELD score. And you'll see that although there was great reduction or great improvement in the control of bleeding, the overall survival was not significantly different at 1 year. So I think that tells us that perhaps we're looking at the wrong people and we need a better definition of high risk. I don't think there's any doubt that tips can improve survival in some people. We just need to find out who those some people are. And then we come back to MELD score. So MELD always comes up, doesn't it? It's standing the test of time, and people looked at MELD as a way of predicting poor treatment outcome or poor outcome in patients with variceal bleeding. So this is 178 patients, all treated with standard of care, banding, antibiotics, vasoactive drug, prior to the early TIPS era. And what they attempted to do was to look at how well MELD performed in predicting survival or otherwise. And it performed reasonably well in the derivation cohort, which was from Barcelona, but when they applied it to 2 other cohorts, it didn't work quite as well. So they recalibrated recalibrated the MELD with a slightly different formula. And what they then found was they had a way of predicting mortality that worked in Barcelona, that worked in Canada, and amazingly, and I think the strength of this study, is that they were able to show in those 3 panels at the bottom that this recalibrated MELD was able to predict 5% mortality and 20% mortality at exactly the same cutoffs in each of those 3 groups, suggesting that this is quite robust and transportable. And the table on the right shows that there's a definite increase in mortality as you progress up through the MELD. And if you take your cut points of being a MELD of 19 or less, or a MELD of 11, then that corresponds to a mortality risk at 6 weeks in excess of 20% or less than 5%. This has now been validated in an American cohort, very large, multi-center, 523 patients. And what they sought to do in this study is say, well, okay, let's look at the outcome of these patients and let's see what happens to the people who are low risk, as according to the original TIPS trial, and those people who are high risk. And as you might expect, if you're low risk, Child A or Child B with no active bleeding, your mortality is low. If you're Child A, it's really low. So if somebody under your care dies with Child-Pugh A of variceal bleeding, it's almost an auditable event. If you've got Child-Pugh B with no active bleeding, then the mortality is intermediate at 11.7%. Whereas if you've got Child-Pugh B and active bleeding, the mortality is exactly the same, 11.7%. So Child-Pugh B with active bleeding does not really represent a high-risk group. Whereas if you use MELD and you use a cutoff of 19, you can see that if you've got a MELD score of less than 19, depending on whether it's less than 11 or 12 to 18, that's either very low mortality, intermediate, or if your MELD is greater than 19, then that's nearly 50% mortality at 6 weeks, which is really quite powerful, I think. This needs to be validated more, and what we don't know is whether these patients are actually going to be the true ones that really do benefit from early intervention with TIPS. So it's always nice to end with failure to control bleeding, and this was a bit of a change from Baveno 5 in that there were 2 things that they made a statement about. Balloon tamponade, they're saying, can still be used, but has a high incidence of adverse effects, and they're suggesting that an alternative to balloon tamponade would be insertion of a self-expanding metal stent. Now, I think this is where maybe Baveno got a little bit ahead of itself, because Sengstaken Blakemore tubes have been around for years, and many people in this room will have grown up using them, use them safely, use them to great effect. Never nice to end up having to use them, but I think the data supporting self-expanding metal stents, and I'll put my hand up and say that I was a proponent of those, is pretty weak, and I'm not sure that, I think that statement is rather grand. I still think that an SB tube is a useful treatment, but because as we remember the start of the talk, we said that people dying of acute bleeding is very rare now. I don't think trainees are actually getting exposure to the safe use of this device. And that's when you end up in a situation like this, when you have somebody who's had a Sengstack and Blakemore tube with the gastric balloon blown up in the esophagus. And you deflate the balloon and you end up with a tension pneumothorax, but you go down to have a look and there's this massive rent in the esophagus. So this is where actually something like a Danis stent or a self-expanding metal stent is actually really helpful. So for those that have not come across these, this is a Danis stent. It's a stent that's been designed specifically for the use in variceal bleeding to tamponade esophageal varices. The stent itself is on a plastic delivery system which goes into the esophagus over a rigid guide wire. There's a balloon on the end which is then inflated in the stomach, and you can't inflate it anywhere else because there's a pressure valve, which means if you try and inflate it against resistance, the valve blows off. You then use that balloon to anchor the distal end of the stent at the gastroesophageal junction whilst you deploy the stent. Then you deflate the balloon and you leave the stent in situ. So going back to our patient with his esophageal tear, that's pretty nasty. And he had a stent placed, and it actually did really well. So he had his stent there, he had a TIPS put in, and he survived to leave hospital, and this was the picture of his esophagus about 3 weeks later when the stent was removed. So I think they are useful. The data supporting their use is pretty slim. None of these are very big series. You'll notice that all of them describe a hemostasis of esophageal varices by SEMS of 100%. This is not a treatment for gastric varices, and I accept there is probably massive reporting bias in these small series. Nonetheless, the Barcelona group decided they would need to do a randomized trial of stenting versus Sengstack and Blakemore tubes for massive bleeding or failure to control bleeding, and they published this in, it was Gastroenterological in Hepatology. Very small study, quite a murky primary endpoint of bleeding, death, or freedom from a serious adverse event, and they looked at 6-week survival. None of these differences in the survival curves are significant, but what they did find was the incidence of serious adverse events was much lower with the stent insertion rather than the SBT. Now, whether that's just poor technique with the Sengstack and Blakemore tube, I don't know. But I like to have a Danis stent around. I think they're a useful thing to have in your back pocket, and I think they're especially useful for people who've got complications of therapy. Now, I mentioned earlier in the talk about sclerotherapy and ethanolamine and things like that. Never use it. So this is somebody who was transferred into our unit who'd had ethanolamine, had really deep ulceration in their esophagus, had a TIPS, carried on bleeding despite a TIPS, and had these really nasty, horrible ulcers in the lower esophagus, bleeding away. So this patient had a Danis stent inserted. So the guide wire goes down, the scope comes out, and then the rigid plastic stent delivery device is placed over the guide wire. Can't see that bit endoscopically, obviously. And then the stent is placed, and that very nicely solved that lady's problem. You can see the distal end of the stent is just nicely deployed at the gastroesophageal junction, and just peeking out into through the GOJ there, and that's a very nice result. And again, that sorted out that lady's problem, and she survived to leave hospital. So, is portal hypertension still relevant? Well, I think it is. We've got quite good at it, but there's still a lot of variation. There's loads of techniques that need to be standardized, and we can study what's best, and we still really need to look at this risk stratification and access to early tips. We also need to address this gap between early and late morbidity and mortality. And the only way we can do that is by addressing aggressively portal hypertension. And that's where I'll bring Jason in a moment. We do need to identify patients at risk. And I'm not going to dwell on this because this is a really complicated study. This was published just this year in Gastroenterology or Hepatology, from Candide Villanova. 3 hemodynamic studies, step-up treatment, nadolol plus nitrates, nadolol plus prazosin and band ligation, and then looking for response all the way through and really stepping up treatment. Whereas the control group had what you might consider the best standard of care from the beginning. What they showed was that HVPG-guided therapy improves survival, but I think more than anything, what they show in that panel on the right is if you're a responder to any therapy, you do well. But to be able to be a responder, you need to be able to measure it. And that's where I'm going to bring in Jason. Just go straight into there then.
Yeah, they said we have to switch.
Okay, sorry about it. Yeah? There we go. Cheers.
Thanks very much, James. That's a terrific overview of the Baveno recommendations and varicose bleeding. While Jason's just setting up, any immediate questions at all for James? We'll have a chance for some questions at the end as well. Are there any particular questions, Mark?
Thanks, James. That was really, really interesting. You didn't touch much on the primary treatment of varices. What are your criteria for someone who hasn't necessarily had a bleed, but you see some varices that look fairly big? Are you worried about the stigmata that you see, or are you worried about how systemically unwell the patient is from their decompensated liver disease? What are the criteria that you use for primary?
So you're talking in a primary prophylaxis situation. So the question is about primary prophylaxis. I'm a big believer in beta blockers, mainly because in the UK, where we've got one eye on the cash, it's much cheaper than banding. I don't get frightened about giving beta blockers to people with red signs or, very angry looking varices. I know people might say, well, tempted to put some bands on, but you don't know whether that patient's a beta blocker responder or not. And 40% of these people will respond beautifully to beta blockers and be protected from variceal bleeding. So if you ban that individual, you're just giving them a risk of bleeding from banding ulcers, which they don't need. So I would always try for beta blockers, but I always follow the patients up quite closely. I'm quite aggressive with beta blockers. I'm not a big believer in 10 milligrams BD of propranolol just because they can tolerate it. They need to be on a decent dose, at least 40 milligrams BD. I'd love to be in a situation where we could actually dynamically measure response easily, but we're not. But certainly my first line is beta blockers. Apart from in patients with ascites and hyponatremia, and they need banding, I think, or transplant.
Any other questions before we move to a way to measure their portal pressures with Jason? Thanks very much.
Thanks very much, Richard, for the opportunity to contribute to this session. So as James had thoroughly mentioned the implications of knowing the gradient, my talk is just a small part to, hopefully describe a method that we can procure this data the gastroenterology way. So I'm just taking you right back to the history of this. There's many groups in the States had thought of this approach many years ago. So back in 2004, a group in Massachusetts General had thought that endohepatology is an important aspect to pursue, and from their point of view they were looking to measure the portal pressures under US guidance, and they used 22 gauge FNA needles in 21 pigs. Back then, of course, they encountered a lot of technical issues, and that was particularly bleeding around the duodenum, and therefore this prevented the authors from pursuing further studies. What they did was they measured the portal venous pressures directly, and they did not calculate a gradient because they didn't measure the hepatic venous pressure, which is a little bit more technical than just accessing the portal vein. A few years later, the group in Johns Hopkins thought they would approach this with a different method. Again, US guided with an FNA needle to gain access into the vessel. Through a wire that passed a small ERCP catheter to measure the pressure. The back end of the setup was identical to a interventional radiology setup for registering of the pressure measurements. And as you can see, they also had technical issues as the pressures that they had varied between 11 to 41 millimeters mercury. However, they didn't encounter any complications with their technique, but again, it's only a isolated portovenous pressure measurement and no gradient was calculated. Then it's taken a long time before another group, and this is the Harvard group, headed by Chris Thompson, who does a lot of interventional endoscopic procedures, who used, again, a US needle to access the portal vein. And they passed a cardiology pressure wire through the needle and into the vein to measure pressure. So they had a digital output for the first time. Again, they measured the portovenous pressure, but not calculated gradient, as they did not access the hepatic vein. But their conclusion was, of course, in an animal model, this is feasible and it's safe. And most importantly, it was quite similar to the interventional radiology method. So in the same year, we published our data on a different approach. We used a smaller needle, so a smaller footprint, 25 gauge needle. We had a novel manometer, which gave us 3 readings per second on a digital screen. And we correlated this with the interventional method, of course. We also used a portohypertensive model. It was not a cirrhotic model. We essentially flooded the animal with high osmotic fluid, so that didn't affect the gradient per se, but that was just to demonstrate that it's able to register pressures higher than the normal portal pressure. We measured both venous and arterial pressures, and therefore, as you can see on these 4 graphs, there's a cluster of low pressure. This is the EUS, and that's the transjugular IR method. And we'll also measure the aortic pressure, which is right up there. And so you can see the correlation is quite good. We didn't survive the animals, however, but we did not have any complications. And in the interim, we're doing a lot of EUS guided liver interventions as well, and therefore we were comfortable enough to take this forward to a human pilot study. And so the following year, we had 28 patients where they presented with abnormal liver function test without an obvious cause otherwise, for example, cholestasis or biliary obstruction. They were divided into low probability and high probability for cirrhosis. Essentially anybody who had a clinical feature, for example, spider nevi, they would be classified high probability for cirrhosis. Laboratory findings, for example, unexplained thrombocytopenia otherwise, or coagulopathy, imaging such as, nodular liver, for example, endoscopic evidence, for example, varices or portohypertensive gastropathy. So there were many criteria which could land the patients in a high probability group, and if patients did not have any features, they were low probability. We did have some exclusion criteria, given that this is a human pilot study, and we excluded post-sinusoidal portal hypertension. So just quickly, this is the kit that we use. So it's a standard needle which we use now. So most people are familiar with the needle. We wanted to keep the procedure as simple as possible. This is just a non-compressible tubing to ensure that pressure is not dampened or lost through transmission. And this is the a small digital novel manometer, which is very accurate. We do in order to measure pressure, you need to have a fluid column continuously joining the manometer to the portal vein or hepatic vein, and the fluid we used was heparinized saline to prevent clotting at the end of the needle. So the targets are, as the two targets we need to derive the gradient. So one is the portal vein, which is very easily accessible. And as you know, the portal vein is a target of a lot of other therapies, especially pancreatic cancer cell quantification. So schematically, the scope is in the stomach, and usually via the transgastric mode, we can access the portal vein quite easily. We generally don't need to enter the duodenum, which is a little bit more difficult. And then we can then target the hepatic vein in any order. It doesn't have to be the portal vein first, but again, it's a transgastric approach. And as you can see there, our target is, you can magnify this, so the target's generally quite easy to reach. So just got a quick video there. One of the issues that we encountered while we were trying to develop this method was that there wasn't actually, at that time, there was not an actual atlas for EUS anatomy, liver anatomy for EUS. It was more of an uncharted territory, as you know. This EUS is done mainly for pancreatic work, other lymph node, biliary, etc. No one's really looked in detail into the IVC or the hepatic vein or portal vein per se. The portal vein was just used as a guide to proceed onto the pancreas at that time. So we're just sort of highlighting the anatomy. I'm sorry about that. So that's the needle coming in there. It's again, just remember this is a 25 gauge needle, so it's very small. Usually it doesn't take that long to get there, but this one was particularly deep. Sometimes they're sort of up here, so it's a little bit closer. And so you can see the tip of the needles there is within the vein. We flush, half a mil of the heparinized saline to clear the end of the needle in case there's any tissue or liver tissue, and that'll give us a reading. And the reading actually comes quite quickly. And that's just the portal vein. The portal vein is a little bit tougher to stick due to the tissue around the edge of the vessel. Yeah. So, and again, this is a 25 gauge needle, so it's very easy to pierce these vessels. And then we take the measurement there. So both measurements are direct. And so, it's just a small study. It's only 28 patients, but we didn't have any technical problems. There was no equipment failure. There was no adverse events. Patients woke up and couldn't tell if they've had this done. So overall, that was quite pleasing. In terms of results, so if we could just focus on the circled data in pairs. So the patient had the high clinical suspicion for cirrhosis, as mentioned by the previous criteria. They had a mean, portal pressure gradient of 10 or more. If they didn't have any of those features, then 3.8, and it was quite significant. So just for the trainees in the room, portal hypertension is defined as your gradient being more than 5. Clinically significance more than 10, and the higher you go, the higher risk for bleeding and so forth. So as you can see, that's above 10. If they had varices, it's 14 versus if they didn't, which is 4. Portal hypertensive gastropathy is less reliable, but even so, you still have a 12 versus 6, and it was significant. And if they had thrombocytopenia, again, it's a little bit higher versus if that wasn't there. So the study has been progressed a little bit. Again, still slowly. There's now 51 patients instead of 28. And the summary of the results really is that the gap between the high-risk group versus the low-risk group, or the present group versus the absent group, has enlarged, and the p-value's dropped, simply because more patients are in the cohort. So it seems to be quite accurate from that perspective. And these numbers, they do make clinical sense. Unfortunately, there were 3 patients out of the next 23 who had mild abdominal pain that was just managed with oral simple analgesia. So where to from here? Well, the to us, the data makes sense at the moment. It seems to be a safe procedure, but certainly 51 patients is a very low number. And obviously the patients were, there were exclusion criteria, so we're doing the less sick end of the spectrum. We need further studies, obviously, and we need a multi-centre study, and that's underway. The regulatory approval is it's very difficult, given that we're accessing vasculature directly, intentionally. But anyone who's done the US, we've all accidentally hit blood vessels. So it's I guess depending on which blood vessel you hit, but generally it doesn't cause that much problem. I've had the luck of I was FNAing a pericardial lymph node with a 19-gauge needle in the chest, and the patient had an ectopic beat, and so the needle went into the right ventricle. But that was fine as well. The patient didn't even develop a pericardial effusion or tamponade. So I'm not saying the liver patients are that forgiving, but with a 25-gauge needle into a low-pressure system, you would imagine that it should be relatively safe, but obviously there are other considerations such as infection in immunocompromised patients. And altered anatomy if they've got significant caudate lobe hypertrophy, for example, which could increase the technical difficulty of the procedure. So there's so far 1, 2, 3, 4, 5, 6. There's 7 centres which are collaborating to move this forward, and hopefully in the future this will work out. But I guess just watch this space. All right.
Jason, do you want to take some questions now? Because that's quite an amazing technique, isn't it, really?
Yeah, any questions?
Any questions for Jason? Can I ask how long the procedure takes, and if you're doing a standard endoscopy and you do tack this on?
Yeah, so that's a very good point that I didn't mention. Of course you can tag on a US to any endoscopy if you're screening for varices or, I guess, dare I say, in an acute setting. To get one reading, so what we did was we followed the standard protocol of IR, so they did 3 measurements to ensure that the measurements are consistent, I guess, in a way, kind of like FibroScan, but you do more just to make sure the numbers are correct. So each measurement probably takes anywhere between 60 to 90 seconds if you do it slowly. And then every time you redo that, you essentially reprime the system, so you just flush some fluid through to unclog the needle, regenerate the pressure, which then equilibrates. So do that 3 times. If it's consistent, you register that as a reliable reading. So that generally takes perhaps 5 minutes to do the 3 readings, but certainly it takes perhaps another 5 minutes to find your landmarks and so forth, and just make sure at the end you monitor to ensure that there's no bleeding. So probably 10-15 minutes.
Any other questions? Brad.
As a non-hepatologist, can I ask why? It's IR, is it interventional radiology technique, difficult, dangerous? I'm just interested to know why this evolved, that a need was seen to develop this technique.
Yeah, so very good question. So first of all, I guess everything we're doing with the US, we're sort of increasing our footprint. We're going towards sort of surgical, we're draining gallbladders. There's animal data to show that we can do, gastrojejunostomies. We're draining pseudocysts, which used to be surgical territory. So from an IR perspective, if they don't do enough of these, they're actually quite bad at doing them, and then they don't like doing them, then you can't get them to do them. So obviously the expert centres, they're happy to do that, but I don't know how many centres, for example, even around our country, especially in the States, for example, most IR practitioners don't want to do this. I'm not sure exactly the reason in the States to start this sort of attrition of skill, but certainly that presents us with an opportunity. And in addition, we can, when we're doing the endoscopy, which we need to do, we can just tag on this US relatively simple method, and that way everything's packaged. If this is proven to be safe and accurate and enters mainstream practice for patients who are on treatment, for example, who require multiple measurements, it perhaps makes more sense to have an endoscopic method rather than multiple transjugular punctures.
I've got time for 2 more slides.
Yeah, of course. And I think, Brad, also it would help us identify the patients who are responders and non-responders to beta blockade. I think that would be a useful thing to do, because most of the literature is about your response. And if you're not working with non-selective beta blockers, you ought to try something else.
Excellent. I've got a completely different view to answer your question, Brad. I think the reason why interventional radiologists don't like doing it is because it's too easy. And they find it very tedious, and they often don't do it well because they're not invested in the result. But really, to do a wedge pressure, you only need 3 bits of plastic, a guide wire, and a monitor. And the very important thing is an Italian research fellow, because they're very good. And it's very quick, it's very cheap, and there is this sort of mythology that's grown up around about HVPG measurement, which is driven, I think, mainly by research centres in Europe saying, oh, it's not widely available. It's a very easy technique, and if you can access the internal jugular vein, then you can do a wedge pressure. It's really very, very simple. And I think your technique is fantastic for those situations, because what you can't do with a wedge pressure is access portal venous blood. Whereas you've got access there quite safely by the look of it with portal venous blood, which is a gold mine. So I would urge you to start looking in the portal venous, because that's almost like the blind side of the liver for a hepatologist. But you can do lots of things with if you've got a decent HVPG service. And I'm just going to show you that, I think we're moving away, hopefully, from direct measurement of portal hypertension into serum biomarkers of portal hypertension. Serum markers of angiogenesis is one, and then the other thing I think it probably has some mileage in it is spleen stiffness. And whilst people are coming for ultrasound, for endoscopies for sure, they're also coming from ultrasounds quite a lot. And I think if we can build into our practice routine measurements of spleen stiffness, as long as that's validated for all the different machines that are out there at the moment, I think that might be quite useful. This was a really interesting, very small study that just looked at the dynamic response of spleen stiffness to TIPS insertion. And whilst this is small, I think it just shows that even within a few days, you can see a reduction in spleen stiffness after an acute intervention like a TIP. So I think there is mileage in the spleen. And we've started a protocol, Sunshine Coast, using these little fellas, which are disposable ultra-thin gastroscopes, to actually do varicose surveillance in the clinic. At the same time, the patients come for their ultrasound, where we're going to measure spleen stiffness at the same time, to see if we can actually make the link between clinical portal hypertension, varices at high risk of bleeding, and the spleen. Watch this space. So, thanks, Jason. That's really, I must talk to you about that, because that's a really promising technique for a number of reasons. There's much to do in portal hypertension, and assessment of risk at all stages is key. And I think that forums like this will allow us to talk about collaborative studies, because there's obviously some exciting technology around. And thank you very much for the Society for inviting me. Thank you, Richard, and thank you for the warm welcome, not just to this meeting, but also to Australia, because I'm still very new here. Thank you. Sorry.
Do we have any question? Sean.
Thank you, James. I just wanted to ask you a quick question about the outpatient unsedated endoscopy. It's a really interesting concept, because after all, IBD people are already doing intestinal ultrasound and in an outpatient setting, so this could be the next liver outpatient setting that could be done. But I'm curious if you could share your experience. Are patients willing, first of all, to have this unsedated? And in your experience, what's the uptake like, and what are the findings that you found?
So we've only just started. The first person in the hospital to have it done was me, sat at my desk, and actually it's very tolerable. The scope's only 3.2 millimeters in diameter, and it's done under throat spray sedation. Now, there is a mission, I think, in terms of the acceptability of unsedated endoscopy. But I can tell you that in the UK it's accepted and people have it, and that's with normal size scopes, and they survive. So The project hasn't started proper as yet because we need to sort out the algorithm for the spleen stiffness because the machine has changed, and apparently the software, even if you deploy it on different machines of the same model, isn't the same, bizarrely. So the project proper hasn't started, but all the procedures are in place, and the patients actually, I mean, where I work, I have patients that come down from Gympie and further, and they don't want to see a hepatologist and say, oh, right, you need an endoscopy, so here's an appointment, I'm going to send you an appointment, you have to come back on a separate day, find somebody else who has to take a day off work, you have to take a day off work, and then it's a whole palaver for actually, how long does a varicose surveillance endoscopy take? Yeah, 2-3 minutes, you know. It's a massive waste of time, resource and money, I think. So that's the angle that we're taking with this. And because they're disposable, there's no reprocessing costs, and it's just all done there in the outpatient department.
I hope you don't mind, just have a second in. Just with the quality of the image, just the quality of the image that you get with that scope, and if you don't mind me asking you to put that picture back up because I'm curious about the equipment.
Yeah.
That'd be great, thanks.
Okay, back on. So you're right to ask the question. There are 7 studies which have looked at ultra-thin endoscopy compared to conventional endoscopy in terms of image quality to be able to diagnose varices at different stages, and the inter-observer agreement is very, very high, like 99%. It's the technology is really the tip of the scope is essentially the same technology as a video capsule. The light is not very bright, and there is a learning curve, and as I found out on myself, if you over-distend the stomach, then it's a bit like holding a candle in a cave, you know. So I think, for a full endoscopy down into the duodenum, and visual inspection of the mucosa of the stomach, that's not what it's there for, really. It's there to look at the esophagus and the cardia, and it's very good at that as long as you don't over-distend. And I can tell you that if you do over-distend, it's quite uncomfortable because there's no suction button. So that's the learning curve, and the best way to do a learning curve is do it on yourself, and then you learn what works and what doesn't work. And so as long as you don't overextend, the image quality is excellent. I mean, for the esophagus, it's just, fine. It's indistinguishable almost.
Any other questions? All right, well, I'd like for you to join me in thanking both James and Jason. We traditionally, for our liver talks, give out a bottle of wine, which is always... Thank you. Thank you. And thanks. Cheers. And of course, thank you once again to Gilead for sponsoring this evening, and thanks to all for attending, and hopefully those who watch the webcast as well. This is something that we'll probably start to do with these talks, so they're available for people to go back to and look at again, which I think will hopefully stimulate education and collaboration, things like that. So thank you once again.